And I believe that is it. So take it away, Lauren.
Thanks, Elena. Well, good morning, everyone. My name is Lauren Geiskamper. Before I get started today, I just want to let you know that I would love to continue this conversation with all of you on this topic. So if you learned something new from this presentation or would like to maybe ask a further question or have more details on something, please feel free to email me. I'll be looking forward to hearing from you. My email is listed here on the screen, and I will also have it while I'm taking questions at the end of the presentation. So have you ever had a patient been told by their doctor that they have high cholesterol? They might have been encouraged to either go on a statin or eat a low cholesterol diet. And this is what my grandma was told a couple months ago by her doctor. But now we know there are better answers to this than taking a statin and eating a low cholesterol diet because of the new evidence and research that we have. So this is my grandma. She was told that she had high cholesterol last September by her doctor, and her doctor told her to go on a statin. But being the way my grandmother is, she refused to go on the statin and told her doctor she would like to try lifestyle changes and diet. So my grandma's super healthy. She's not overweight. She's always eating vegetables. She's very active and goes on 2 walks a day. And she's always carrying a water bottle with her. But you might be very surprised to hear that she's very into naturopathic medicine, essential oils, meditating, drinking clean water, and basically anything that has to do with health. But she wasn't always that way. She was raised on a farm with her 7 siblings, milking cows and raising chickens, eating a typical American Iowa farm diet. She then went on to raise 4 children and now has 10 grandchildren. She had a lipid panel done in May and September where her total cholesterol jumped higher by 55 milligrams per deciliter in just 5 months. Her HDL and LDL increased and triglycerides decreased. So with this sudden spike in high cholesterol, she was worried, but her doctor really wasn't. And this is probably because it's very common nowadays to have high cholesterol. "50% of people in the world have elevated cholesterol, but cholesterol is only one risk factor for looking at heart health, and it's maybe not even the best risk factor to look at for measuring heart disease." So first I'm going to be going into some background information, and then I'll go into a few research studies about dietary cholesterol, fatty acids, and testing techniques. I will end with summaries and key takeaways. So think of it like this. Think of the cholesterol like the dirt, and the dump trucks are the particles carrying around the cholesterol. So it's not so much about the amount of dirt someone has, it's about the amount of dump trucks they have carrying around that dirt. And the size of the dump trucks matters too. So it's not about the amount of cholesterol someone has, it's about the amount of particles they have carrying around the cholesterol. And the size of the particles matter too. If we have these small particles, it can be more concerning because they can be small and dense and cause a plaque buildup that can get into small blood vessels, and we can't get rid of those particles as quick. Heart disease is the #1 cause of death. However, cholesterol is only one risk factor for measuring CHD, and high cholesterol is only high in about 50% of heart attacks that occur. Our bodies can make all the cholesterol it needs, but we don't actually need it in our diets because our tissues are able to synthesize enough for our metabolic and structural needs. And this is why there's neither an adequate intake or recommended dietary allowance set for cholesterol. And this is because cholesterol you consume is not the leading factor causing our high cholesterol levels in our blood. So let me repeat that. The cholesterol you consume is not the leading factor causing high cholesterol levels in our blood. Now, I could show you just one study of how dietary cholesterol doesn't significantly change our cholesterol levels, but this meta-analysis might be more credible to show you hundreds of studies that support this idea. So this was a secondary Class M study that looked at 224 published studies on over 8,000 subjects between 1966 and 1994. They reported data changes in dietary cholesterol and fat intake with the corresponding changes of serum triglycerides, cholesterol, and lipoproteins. The dataset consisted of a published study that met the following criteria. First, the dietary interventions had to occur on adults over the age of 18. The published study must be between the years of 1966 and 1994. And they also used studies that reported quantitative measures of dietary components such as cholesterol, total fat, saturated fat, and poly and mono unsaturated fats. They also used studies that reported the group means of standard deviation for LDL, HDL, VLDL, and serum triglycerides. So just know there was many criteria that had to be met to be evaluated in this meta-analysis, and that they were very selective on which studies they could be used. So there's little debate that lowering our bad cholesterol can reduce the risk of coronary artery disease. However, the dietary modifications to achieve this is what is the controversial part. So in 1988, the National Institutes of Health claimed that 100 milligram increase of dietary cholesterol could increase our plasma cholesterol by 4 milligrams per deciliter. In contrast, all the studies published since 1990 were presented in this meta-analysis, which suggests a rather narrow range of plasma cholesterol reduction, stating 100 milligrams a day of decreased cholesterol would result in only 1% decrease of cholesterol concentration. So this means the cholesterol reducing eliminating diet won't be as beneficial as we once thought. So here's a quick timeline to clear up why there's so much confusion on the cholesterol recommendations. So first off, in 1951, they reported the first link of abnormal levels of cholesterol and CVD. In 1968, the American Heart Association announced a dietary recommendation to consume less than 300 milligrams of dietary cholesterol per day, and also no more than 3 egg yolks per week. So after this happened, there was a negative effect on the egg industry for many years. So that was when the Egg Nutrition Committee was created in 1977. 10 years later, lovastatin was the first statin commercially developed for clinical use. And in 1999, the first large long-term study was published to show that there was not an association with CVD risk in eating 1 egg per week versus 1 egg per day. So 3 years later, in 2002, the American Heart Association dropped the egg restriction of 3 to 4 per week, but they kept the 300 milligram per day recommendation. And finally, in the 2015 dietary guidelines, it quietly came out and said there was no longer an adequate intake or recommended dietary allowance set for cholesterol. So one thing that is associated with higher concentrations of LDL is that high dietary saturated fat can increase our cholesterol. However, there's an increasing interest whether certain dietary oils and fats with various fatty acid profiles, such as coconut oil, may have different metabolic effects because of its unique chemical structure. So this was a Class A randomized clinical trial conducted between June and July of 2017. It included 94 healthy men and women from the UK, ages 50 to 75 years old, with no history of CVD or diabetes. The study measured changes in blood lipid profiles, weight, fat distribution, and metabolic markers after just 4 weeks of consuming 50 grams of an assigned dietary fat. And they either were assigned extra virgin olive oil, extra virgin coconut oil, or butter. So here are the results of the study. After 4 weeks, the olive oil and coconut oil decreased the bad cholesterol an equal amount, and then the butter increased the bad cholesterol by quite a bit. As for the good cholesterol, there was an increase in olive oil and coconut oil, but coconut oil was by a lot more. Butter also increased the good cholesterol by a little bit too. And there was no significant changes in the patient's weight, BMI, central adiposity, fasting blood glucose, or blood pressure, and this was probably because the study only lasted for 4 weeks. So the study results may surprise you because there's new nutrition concepts that we previously didn't understand. So even though butter and coconut oil are predominantly saturated fats, they appear to have different effects on our blood lipids. Coconut oil can have a more comparable effect to olive oil because of its result to the LDL cholesterol. And this is because coconut oil contains lauric acid, a medium chain fatty acid that is rapidly absorbed and taken up by the liver, and then it's oxidized to increase our energy expenditure. And this is why coconut oil may have different effects than compared to other saturated fats such as butter. So we understand the effects of dietary fats on lipid profiles and how they can change our health outcomes, but they may not be aligned with their general classification of either saturated or unsaturated fats. And perhaps the dietary recommendations for saturated fat need to be clarified with their relationship to health. So there are several nutrients for treatment of high cholesterol, but here are just 4 types of treatment where nutrients can benefit. Many of them include choosing the right type of fatty acid. Plant sterols are a plant substance that can resemble our cholesterol, and this helps the body by limiting the amount of cholesterol that is able to enter the body, and also how much cholesterol is made in the body. Niacin, also known as B3, can increase our good HDL cholesterol and also lower triglycerides. You might see omega-3 listed on this list quite often, and that's because it can decrease our triglycerides, but there isn't sufficient evidence that it lowers our risk of heart attack yet. So studies on fish oil have been mixed on their ability to lower our LDL. So my last study looked at if LDL particle size could categorize more patients at risk when compared to measuring the number of LDL, HDL, and triglycerides. So in this study, a little over 1,000 end-stage renal disease patients were included, and they had a blood sample collected of 20 milliliters after fasting for 12 hours prior to their dialysis appointment. And each patient got a standard lipid profile done with additional lipid testing using NMR spectroscopy, which I will talk a little bit more about in a minute. And there's only a few studies out there that have looked at this comparison of measuring cholesterol number versus cholesterol size. But the cholesterol measures were used as measurements of disease outcomes, and in this case, it was end-stage renal disease. The National Cholesterol Education Program has yet to endorse this type of measurement of NMR spectroscopy because there's a risk prediction, and this technique is labeled as an emerging risk factor. So they're going to continue looking into it if it's valuable to keep or use as a standard test. So LDL particle size may be helpful to identify those patients who are considered at risk rather than just using LDL particles, HDL, and triglycerides alone. Our particle size should be used as a further screening measure because it's more predictive of our coronary heart disease outcomes. The LDL particles can have an improved, knowing our LDL particles can help us decide if we need to improve our treatment decisions. because our small and dense LDL particles can have a less affinity for binding with our LDL receptors, meaning the LDL will spend more time in circulation and increase their exposure to the arteries, and also it will increase the susceptibility of oxidative stress situations, which can lead to disease. The LDL particle size may be a risk factor for patients who have normal levels of LDL, and more studies need to be conducted to look at the outcomes of cardio events and mortality. So the key to understanding whether cholesterol creates a problem is to get the right type of cholesterol test. And 99% of doctors aren't doing this right test. Most doctors are stuck doing an outdated 20th century test, but this new measure of test in the 21st century doesn't just measure your cholesterol in the weight of milligrams per deciliter, but it also measures the number of particles that are making up that number and the size of those particles. So most doctors are just ordering a traditional lipid panel that tests for LDL, HDL, and total cholesterol. But the problem is we're missing a lot of information about our cholesterol levels here. So this new test measures, or the old test measures the weight of the cholesterol in milligrams per deciliter. But it doesn't tell you if the cholesterol is made for 500 particles or 5,000. So we should be requesting a particle size lipid panel test. This NMR lipid profile test is an advanced cardiovascular diagnostic test that uses NMR spectroscopy to provide rapid and direct measurement of our LDL particle number and LDL particle size. So this detailed test shows health professionals like yourselves to make a more effective and individualized treatment decision than what is being used in most medical settings. An NMR test is also helpful for people to show normal levels of cholesterol because it gives a deeper perspective on what's really going on inside the body. So this is a picture of an example patient with optimal HDL and LDL levels. But it gives us more information than that. The HDL-P you see on the screen is a direct measurement of the HDL particles, and the small LDL and LDL size are associated with our CVD risk. So if you want to help your patients test their overall risk, you can consider asking their doctor to undertake the following tests. First, you can tell them to get a standard lipid profile done, which includes your total cholesterol, HDL, LDL, and triglycerides. So these tests are typically done, and the patient might already have these done. Next up, I would suggest the NMR lipid profile test, which assesses the size of the cholesterol particles and determines your risk by assessing whether or not you have large or small particles. And this is a very important test because you can differentiate the risk of your cholesterol by either knowing if it's a small, dense, and dangerous type of cholesterol or a large, light, and fluffy type of cholesterol that isn't as dangerous. The third test would be a C-reactive protein, which is a marker of inflammation in the body, and it's essential to help us understand the context of our overall risk. And the C-reactive protein should be less than 1. Homocysteine can measure your folate status and should be between 6 and 9. And if your patients are concerned that they have cardiovascular disease, you might encourage them to undertake a high-speed CT scan of the heart, and this may be helpful to overall assess the plaque burden and also get a calcium score. So a calcium score of 100 is a concern, and over 400 can indicate a severe risk of cardiovascular disease. So these are just some of the tests that I'm going to recommend to my grandma to get done so she can better understand her risk of CVD and knowing if her particles are dense and dangerous or large and safe. So in this presentation, we learned that cholesterol we eat doesn't significantly change the cholesterol levels in our blood. And from the fatty acid study, we can now understand that the effects of different dietary fats on lipid profiles can have different health outcomes. So their benefits may not align with their classification as saturated or unsaturated fats, because butter isn't as healthy as coconut oil might have healthier benefits. And finally, our particle size should be more predictive of coronary heart disease outcomes, because the small and dense ones will spend more time in our arteries and increase oxidation than compared to the large and fluffy ones. So after learning all this information, we can understand that cholesterol may not be the cause of what we thought it would be. High cholesterol is actually caused by inflammation and insulin resistance in the body. So with cholesterol being high in only 50% of people who have heart attacks, maybe we should be looking at other risk factors for CVD. However, having high cholesterol levels is the first warning sign that our body is trying to tell us something is really wrong. So let's focus on teaching our clients the correct ways of changing their lifestyle as a whole, rather than decreasing their inflammation levels and only focusing on decreasing cholesterol. Here are my resources. And just a reminder, please feel free to email me if you would like to continue this conversation or have further questions after this Q&A. I would love to hear from you. And if anyone has questions, please feel free to either type them in the chat or you can turn on your microphone. My first question from Heather said, did you find anything in your research about what physicians are ordering, the recommended tests to accurately assess cholesterol size and particle number indicating our CVD risk? So a lot of physicians aren't testing the particle size, and that's why I recommend it, because it's kind of a new study out there. But I guess there's certain naturopathic doctors that have kind of started this trend and are looking at particle size. So I think that's why I want my grandma to test it, because her sudden spike in high cholesterol was, maybe it's the good type of cholesterol and maybe it's not as much of a warning sign as we think. So that's kind of what my research found on that. So next question is, how available is NMR spectroscopy? So it's actually kind of easy to do by yourself. You can order a test if your doctor doesn't want to do it, and it's actually only about $100. So somehow you will need to get a blood sample from your doctor, but then that's how you can kind of just mail it in to this company online, and they can test it for you and give you results. It might be more beneficial to have your practitioner be able to explain those results to you, but yeah, it's actually easy to do on yourself. So I'm thinking it may be hard for patients to know where to obtain these tests. I used to interpret these results when I worked at a fitness center. I love that you dug into this new research. Thanks, Heather. Yeah, this is really kind of a passion of mine, just because I'm trying to help my grandma learn even more about this topic, and I presented to her last night. And that was her first concern too, was how is she going to ask her doctor about obtaining this test? And I just said, you don't know until you ask, and kind of, if you bring all this information to your doctor and tell them the reasons why you want to get this new test, maybe they'll be in support of you to try something new. Michelle asked, do you know if calcium score is more diagnostic than NMR? No, I do not know if it's more beneficial. Um, I guess the research that I was looking at kind of was only focused on NMR, and then it listed a couple backup testing techniques, and calcium score was farther down the list. So that makes me think it wasn't as important of a test, but I'm sure both would be highly valuable. If you can't get an NMR test by your doctor, I would say a calcium score is the next best thing.
And I also just want to say I did put the eval again in the group chat. So if everyone could please take some time and fill that out on Lauren's presentation, that would be greatly appreciated. And also I just want to point out that the next presentations will start at 9:50, either preeclampsia and nutrition with Chloe or enteral nutrition whole foods blend versus commercial formulas with Caitlin. Thanks, everyone. And if there's also any other questions, please ask Lauren. Thanks.
Thanks, Elena.
You did a very good job, Lauren. I really like your information.
Thanks, Elena.
Mm-hmm.
Thanks, Michelle. Thanks, Heather. Thanks, Nate.
I'm always very interested in that because cholesterol can be a huge thing. People kind of like I was talking to you before with everyone's like, oh, I need to eat lower cholesterol foods and things like that, but it's really an overall problem with everything, with inflammation and stuff like that that can influence your cholesterol, right?
Mm-hmm. Yeah, most people are just told to go on a low cholesterol diet. I mean, my grandma was, and she didn't know any different unless, so good thing she was interested in like researching her own health. Otherwise, she would have been on this insane diet for no reason, and it's not even that beneficial for her. So
Mm-hmm.
I think it's good to just bring up the awareness because most people didn't even know the dietary guidelines changed in 2015, and they still think we should be limiting cholesterol.
Mm-hmm.
Lauren, I really appreciated this because despite like your grandmother being thin and healthy, my cholesterol is high. I related to familiar factors, but I did start out watching my fat overall, and I lost weight, which for me isn't good. So I wound up going on a statin. So I was just really impressed with the information you shared.
Yeah, thanks. Yes, fat is important to look at, but it's kind of difficult to understand whether it's going to be beneficial because coconut oil is a saturated fat, and we just think, oh, it's terrible, like remove it from your diet completely. But my study showed that it actually improved your good cholesterol, so it's kind of just confusing to everyone out there.
I'm curious, what did your grandma all say when you presented this information to her?
Yeah, I presented it to her last night, and well, she was first concerned, like, I don't know how to ask my doctor. Like, my doctor's super outdated, and he's probably just going to shut me down and say, no, I'm not doing this extra test for you. But I just encouraged her to say, if it doesn't hurt to ask, and it might help you in the future. So I would encourage her to get it done. I know she's getting her lipid panel retested, I think in March sometime, so we'll see if like some of her dietary modifications made a difference. But I'm excited to see how it progresses, I guess. Maybe I'm more excited than her, I don't know.
Yeah, that's funny. With that being said, I believe I will stop the recording.